Hello everyone, this is Dr. Madhusudan Rao and the program I teach medical students. My dear students, look at this picture. This is the picture of the preterm newborn getting injection indomethacin for patent ductus arteriosus complicating congestive heart failure. Ductus arteriosus is a very important vascular structure in the fetal circulation that connects the pulmonary trunk with the aorta. During fetal life, right ventricular output is shunted across the ductus arteriosus into the systemic circulation in order to get the deoxygenated blood oxygenated in the placenta. Because placenta plays the role of lungs during the fetal life, the role of patent ductus arteriosus is important during that particular period of fetal life. But it should close soon after birth in order to avoid the complications resulting from the left to right shunt at the ductal level, resulting in the congestive heart failure and the consequences. So this newborn is taking indomethacin as a treatment for patent ductus arteriosus. This is the medical management to get the patent ductus to close. Well, coming to the ductus arteriosus, its embryology, its structure, and the clinical manifestations of PDA and its management in the later part of the life. Well, coming to the previous slides. Well, patent ductus arteriosus. It is one of the common cyanotic congenital heart diseases, and ductus remains open in 10% of the total congenital heart diseases because there is a permanent circulation, there is systemic circulation with lethal congenital anomalies which may be ductal dependent. So, patent ductus, that's the reason why, is a part of the complex cardiac anomalies in order to sustain a life. Well, what is PDA? PDA is a non-public display affection. No. PDA is patent ductus arteriosus. Look at this particular picture. There is a ductus arteriosus connecting the pulmonary trunk with the descending aorta. Well, this picture also shows there is a patent ductus connecting the pulmonary trunk with the aorta. There is the direction of the flow of blood is from the aorta to the pulmonary trunk. Patent ductus arteriosus is a vascular structure that connects the descending aorta to the roof of the common pulmonary trunk close to the origin of the left pulmonary artery. An important vascular structure during fetal life, as I mentioned already. Most of the pulmonary blood shunted through the ductus arteriosus into the aorta in fetal life. To get the deoxygenated blood reoxygenated in the placenta, as the lungs in the fetal life are non-functional, and most of the deoxygenated blood is pumped from the right ventricle to be received by the placenta by pulmonary arteries, the branches of the internal iliac arteries, thereby getting it reoxygenated in the placenta and ultimately received by the heart through pulmonary arteries. This is the importance of the persistent or patent ductus arteriosus during fetal life. Well, functional closure soon after birth, spontaneously. Anatomical closure occurs in a span of 2 to 3 months. Failure to close results in abnormal hemodynamics and the consequences of large PDA in later part of the life, which we are going to touch in this class. Well, PDA is common in girls at 2:1 ratio. Congenital rubella syndrome is a situation where the PDA is a component. Well, as I told you, PDA is associated with 10% of the other congenital heart anomalies. It could be small when it is silent. It could be moderate or large. Irrespective of its size, complications do occur. So, early diagnosis and the intervention to close are very important to avoid the morbidity and mortality. Well, coming to the embryology, there are 6 pairs of aortic arches, proximal 6th pair on the left side to common pulmonary trunk, and distal 6th pair on the left side persists as ductus arteriosus, and the development in the fetal life is complete by 8th week of gestation. This is the diagram of the development of ductus arteriosus. Well, coming to the physiology. In fetal life, lungs are non-functional. Pulmonary vascular resistance is very high. Nearly 60% of the combined ventricular output goes to the right ventricle via the ductus to low resistance systemic circulation. That's why I told you. The right ventricular output mostly goes into the systemic circulation to get the blood reoxygenated in the placenta. And only 5 to 10% goes to the lungs to supply the nutrients and oxygen for the growing lung. Then with regard to the histology, media of the connecting vessels, that is aorta, has elastic fibers which are circumferentially arranged. Media of the ductus arteriosus, spirally and circumferentially arranged smooth muscle. Intima of the ductus is thick with abundant mucoid tissue. This is called intimal bed. This is the picture showing the patent ductus arteriosus. It connects the aorta distal to the subclavian artery. Onto the pulmonary trunk, it connects the common pulmonary trunk close to the branching of the left pulmonary artery. Here, direction of flow is from the aorta into the pulmonary trunk. This is the diagrammatic representation of the patent ductus arteriosus. This is the normal one, closed ductus. This is the ductus that is open. The direction of flow of blood is from the aorta into the pulmonary trunk. Well, what is the pathophysiology? This is after birth, when the ductus is patent. Blood flow from the aorta to the pulmonary trunk, and volume of the flow depends on the size and ratio of the pulmonary and the vascular resistance. In small PDA, the shunt is very small, and normal pulmonary arterial pressure, normal right ventricular pressure, and normal right atrial pressure. In large PDA, because of the magnitude of the left to right shunt is very high, nearly 70% of the aortic blood is shunted to the pulmonary trunk. So there will be pulmonary arterial pressure is elevated in both systole and diastole, a high risk of developing pulmonary vascular disease because pulmonary circulation occurs at systemic pressure, resulting in endothelial damage to the pulmonary capillaries, which in turn react, resulting in pulmonary vascular disease, which could be early in onset during the course of patent ductus arteriosus. There is high pulse pressure because of the aortic runoff. Coming to the clinical manifestations. Small PDA is asymptomatic, normal heart size, no need to intervene. But it has to be closed to avoid the other complications which we are going to touch. Large PDA, there is early onset of heart failure in infants because at birth the newborn may be asymptomatic. With the fall in the pulmonary vascular resistance, there is high blood flow into the pulmonary circulation, volume overloading of the lungs, resulting in congestive heart failure. There is growth failure, bounding peripheral pulsations, cardiomegaly, involving the enlargement of the left atrium and the left ventricle, forced apical impulse. This I told you, forced apical impulse indicates left ventricular dilatation, volume overload. Systolic thrill in the upper sternum, continuous murmur at the pulmonic area, and peak of the murmur is at the end of the systole. That is, murmur is continuous, starting with the first harsh sound and increasing intensity or the loudness, and peak of the loudness at the onset of second harsh sound. And the murmur spills into the diastole, resulting in missionary continuous murmur. You can appreciate mid-diastolic murmur in the mitral area, indicating increased flow across the mitral wall from left atrium into the left ventricle. This is indicative of more than 2:1 pulmonary systemic flow ratios. Diagnosis. X-ray chest is going to show pulmonary plethora with enlargement of the left atrium and left ventricle. Okay. There is dilatation of the pulmonary trunk. ECG shows not much. Maybe there is right ventricular potentials are high with, left ventricular potential, left chest will show high potentials indicating the volume overloading of the left ventricle, and it's not significant, not diagnostic. 2D EQ will demonstrate the presence of flow across the ductus arteriosus. There is increased size of the left ventricle and increased size of the left atrium, and the color Doppler showing the flow across the pulmonary trunk, aorta, flow across the ductus arteriosus from the aorta into the pulmonary trunk. Cardiac catheterization is usually not required for the diagnostic purpose. Well, so what are the complications? Normal lifespan with small PDA. Late signs of heart failure with small PDA. Heart failure in infancy with large PDA, which is the resolution of the pulmonary vascular resistance. Spontaneous closure is unlikely, right? Even after infancy. There is risk of infective endarteritis. We call it endarteritis instead of endocarditis. Embolic manifestations, there is high chances. Eisenmenger syndrome is likely to develop early in children with patent ductus arteriosus. So these are the complications if the PDA is left untreated. What are the treatment procedures? Medical and surgical. Medical management is treat the congestive heart failure, give the prophylaxis for subacute bacterial endocarditis, review the patient repeatedly, advocate early closure of the ductus around 1 year of age. And as early as possible if the child presents late. Surgical closure is usually done by the transcatheter insertion of the coils in small PDA and thoracotomy with ligation of the large PDA surgically. And surgical mortality with the open heart surgery is nowadays less than 1%. And most of the centers, early closure is being undertaken by transcatheter insertion of the coils. In preterm, this management is with injection of the endomethacin and repeated injections, 3 doses of endomethacin, the dose of 0.2 milligrams per kilo body weight is going to result in the closure of the patent ductus arteriosus and the consequences of congestive heart failure and risk of mortality in premature infants. It will be abated with this protocol with indomethacin injections. Thank you very much for patient listening, and we'll meet you in the next class. And look at this particular picture showing the transcatheter closure of the patent ductus arteriosus in newborns. Well, with this, I'll conclude the class today. We'll meet you in the next class. Until that time, bye bye.